Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith-Rogers. Today, Stephanie Desmond talks to Dr. Michelle Decker, founding director of the Johns Hopkins Center for Global Women's Health and Gender Equity, and Dr. Nicole Warren, a nurse and an expert on the harmful practice of female genital cutting. They discuss the dangers of the practice, the challenge of changing long-standing cultural norms, and how they hope to prevent a procedure that affects 200 million women and girls worldwide. Let's listen. Michelle Decker and Nicole Warren, thanks so much for joining me.
Great to be here.
Thank you so much for having us. It's great to be here.
I'd like to start with you, Michelle. Today, I want to talk to you about your new center at Johns Hopkins. It's the Center for Global Women's Health and Gender Equity. So talk to me about what it's about and how it came to be and why it's such a need.
Absolutely. Thank you so much. Well, I think we don't have to go far in the media to see that we're in a really watershed moment for global women's health and women's rights. We see that through the Sustainable Development Goals. We see that through the new inaugural U.S. Action Plan to End Gender-Based Violence, the White House Gender Policy Council, and a number of other domestic and global policy initiatives that are really elevating gender equity and women's health. So naturally, that really gave rise to this new center that we have, the Center for Global Women's Health and Gender Equity. We formed just last year in October of 2023. And our driving mission is to advance global women's health and gender equity through a combination of action-oriented research, training, and translation. Here at the university, we actually have an incredible wealth of gender equity and global women's health research underway and training and translation. And that is really across all of our divisions, public health, nursing, medicine, SciS, at our undergrad campus as well. And so this new center allows us to really synergize that expertise and really bring us into this generation of impact. A couple of our priority areas are around eliminating gender-based violence and other harmful practices, including child marriage, female genital mutilation, as well as empowering women and girls and strengthening health systems to optimize gender equity. It's one of the reasons that we're really excited to have a chance to talk with you today.
Is this sort of an international center, or does it have some domestic components?
Absolutely. We think of ourselves as very global, including the U.S., right? So we've got across our faculty, leadership, and affiliates, we've got people that are working really around the world, but also very much including some of the U.S. priorities and some of the needs that we really have here, particularly around harmful practices.
For example?
Absolutely. For example, gender-based violence. We're going to hear today a little bit about some of the U.S. work on FGM and female genital cutting and mutilation. And we've got gender equity issues right in our backyard here, right? We've got the gender wage pay gap. We've got gender stratification and differential jobs and opportunities based on gender. And we continue to see that gender-based violence is a leading driver of women's morbidity and mortality, untimely death. And it's taking way too many people. So we're ready with the evidence base, and we're ready for evidence-informed change.
Nicole, you are the expert here on FGM, a phrase that she used, and I'm wondering if you could tell us what it means and, why it's not a good practice.
Sure. So first of all, thank you for having me. And it's so exciting to hear Michelle talk about the center because it does have this potential to really provide a space for the complexities of preventing GBV to really get discussed with the nuance and the intentionality that they deserve, because we want them to end, but ending them obviously is going to take a lot of innovative ideas and efforts. So we've been talking about FGM, which is the term, which is the acronym for female genital mutilation. That is a term that the WHO uses, and many people who've been affected use that. Many agencies use that. I tend to use the term female genital cutting because for some folks, I'm a clinician, I'm a nurse midwife. So I often have to think about, can I use language that will be acceptable to my clients? Some folks that I care for absolutely do feel mutilated, and I use that term FGM if that's what they're using. With the exception of that, I tend to use the term FGC because I try to avoid creating that victim-perpetrator dynamic that just isn't consistent with how some affected communities view the result of the procedure. So I'll just put that caveat in. But if you Google FGM, WHO, you can see all the sort of the basic facts. It's a traditional practice that does not have any medical advantages, and it essentially harms some part of the female genitalia. So to be FGM, the WHO would say that you're harming the female genitalia external in some way, and it's done for traditional and not any medical reason.
What is the traditional rationale for it?
Oh my gosh, it's probably as complex as the groups of people who practice it. So I think although many communities would have many different sort of specific answers, a lot of the rationales boil down to things about control, controlling behavior, minimizing the potential for promiscuity, keeping people modest, I can't get away from the word control, but it's really about diminishing the potential for a girl or a woman to be behaving inappropriately. And so for many communities, the act of FGC is actually a way to ensure that she is marriageable. And in some communities, marriage is what allows survival. So the impetus for some families to continue the practice, even in the light of the injury that they recognize is involved, is really powerful, because creating other ways in which girls can succeed other than being married, I think we've come to recognize as an important aspect to trying to prevent the practice.
So this is done in advance of a woman getting married?
Oh, great question. So globally speaking, the average age at which a girl is cut is usually between like 6 and 9. But in some communities, girls are cut in the first week of life. Sometimes they're cut in the first day, sometimes the first month. In other communities, it really is an adolescent ceremony that would be considered sort of a coming of age scenario. But over time, the age at which FGC is done has fallen in many, many communities. And part of that is because communities understand that there are some external pressures trying to end the practice. So there's a little bit of a sense of, let's get this done while we can. There's also some medicalization happening. Doctors, nurses, that has always been going on. But I think now people, as they become more aware of the risks, might seek out medical providers to try and get it done, but hopefully create a little bit of harm reduction in how they do it. And obviously that's a very controversial shift.
I saw a statistic that said that 200 million women and girls have undergone this practice in 30 countries.
Yeah.
And to me, that's a startling number.
It is an enormous number. The prevalence rates can be up in the 80s and 90s. In some countries, they haven't budged in decades. We're talking about half of African countries have some prevalence rate of FGC, but that can vary dramatically. Many African countries do not participate at all. And then we have many countries in Asia, Southeast Asia, the Middle East, who also practice it, but many people don't recognize. For example, in Indonesia, they have very high rates of FGC, FGM, but you'll rarely see that commented on in the media. And part of that is about how we frame Africa in particular, but the numbers are huge. Although prevalence rates are falling in many countries, global fertility rates being what they are, the absolute number of women and girls affected is going to continue to rise just because demographics are what they are. So we're glad the prevalence is falling, but we really need to address other issues like unwanted pregnancy so that we can see those dropping prevalence rates really translate into fewer people being affected.
So Michelle, is this a behavior change type of work?
Absolutely. One of the things that I think is so important to recognize in this from a gender lens is that, we've obviously got a practice, a very harmful practice that is affecting women and girls from a very early age. So there's that aspect of it. But then what you're hearing are these harmful, controlling norms and these norms of really disproportionate and gendered harm and an intent to control, an intent to sort of limit. And these are impacting social, economic outcomes, et cetera, for young women and girls. So it's really we've got to be handling communities at that community normative level and not so much at that individual. It's much more than that individual level sort of prevention. And I think that's one of the things that I feel, Nicole, that you bring so much to this is just this very holistic lens at the community and policy level and moving us away from thinking that, we're going to get there just at that individual level alone.
Yeah. It's really hard for an individual in a community to decide not to participate in the practice because the social acceptability is a big driver. And with that comes a sense of this is how female external anatomy looks most beautiful, looks most proper. So there's a lot of demand for it from men, from women. But fortunately, there are also a lot of people who are against the practice. And we see now in the data, people will say that they would like the practice to end. But right now they're kind of still getting the cutting done because they don't, that risk benefit ratio hasn't quite tilted to help us stop it. So that is happening, I think, much more slowly than we'd like to see.
You can't just tell people to stop doing this, right? I mean, this is a very entrenched thing. Like, how does that work?
Well, some countries have laws, some countries do not. For example, I have worked in Mali for quite some time. They do not have a law in the books. The fear being that it will really drive the practice underground and make an unsafe practice even more unsafe. You could use abortion. You could use that argument that you hear about abortion in this case as well. And then there's just not good evidence that will cure everything, although there is an association between fewer procedures when it is made illegal. But even in many countries where it's illegal, practically speaking, there's no enforcement, there's no follow-up. In some cases, there are large healthcare organizations who have insisted that a country put a law on their books, and because countries want to keep those partners active and those relationships positive, sometimes that drives the law versus a real internal desire to end the practice.
Michelle?
It's just so striking to me. The limitations of criminalizing a behavior like this are a thread across all forms of GBV and gender-based violence. When we think about criminalizing intimate partner violence and sexual violence, really important to have that framework on the books, but it's not a potent deterrent. We've got to really put our public health hats on and be thinking about the normative environment and recognize that policy is one aspect, but it's those social norms and there are other drivers that we really need to address. We're short-sighted if we think we can just criminalize our way out of it, much to your point, Nicole.
So how do we address this, right? So you can't just, as you said, you can't make it criminalize it. That's not going to help. And is it, are there religious leaders who are coming around? Are there other community people who are taking action?
Sure, and this is a great place to put in a plug for the Day of Zero Tolerance for FGM that the United Nations and WHO will have a lot of publications about and letting people know. And one of the themes, I think this was the theme last year, was the involvement of men and boys. So there's this strong sense that the procedure itself is organized and conducted usually by women, but that there's this outside expectation of men in life men in their society who expect the procedure to be done. So engaging men and boys, engaging religious leaders. I want to be clear, FGMC, to kind of put it all together, is not required by Islam or Christianity. And in many countries, you see people of all faiths who practice FGC. So it's not mandated by any religion. However, sometimes communities conflate religion and culture. And so you will find that in some Muslim communities, people will tell you they do it because they're Muslim. That may be because they don't have as a detailed understanding of the religious text than another community might have. So you'll see Christians doing this. You'll see folks who are Muslim and folks who follow traditional religions. It really crosses all kinds of financial, religious, sociocultural boundaries. Ministers of health do it all the way down to folks who would be considered, very disenfranchised and poor.
And you mentioned earlier that there's a U.S. component to this work.
There is. Usually when we talk about FGMC, and understandably so, we're really thinking about prevention. How do we prevent girls from getting cut, right? Because you can't go back. But what happens is after people are affected by the practice, there's a whole range of sequelae, medical, psychological, sexual. I mean, the list goes on. So where the US and other countries where this is not normative get involved is with migration. We've always had migration. It's definitely going to increase with climate change, disasters, and other political challenges. But when people migrate to a place where FGC is not normative, they are introduced to new risks. The risks of facing a healthcare system that don't understand how their body is different and don't even know sometimes the therapies that are available to treat those sequelae. So, of course, we want to prevent the harm that comes from the original cutting. But in the healthcare system, we have a duty to offer people therapies that can help decrease illness and disability. And in the US and in many other countries that host lots of migrants from countries that practice FGMC, the healthcare system is doing a really poor job trying to get up to speed, of course. But unfortunately, in the US, you have over 500,000 women and girls who are potentially affected by this practice. That's about 3 times the number of women who are incarcerated in the US. This is not a small group of people. Yet we have no consistent training for healthcare providers on the topic. We see higher C-section rates, other indicators of poor outcome, and we can solve that. We can address that. We can reduce the risk that people face after they've been cut. And of course, when you can reduce that risk, develop a good rapport with them, provide them good care, maybe provide some treatments, now we hopefully have a trusting relationship to start talking about your plan for your daughter and understand the cycle of prevention. We can start thinking about, what are your plans for your daughter after you have this baby? And start thinking about making sure that primary prevention, preventing the first cut, also happens in the US. The CDC is about to come out with some data that's going to be really, really important. And that'll be very helpful for us to see sort of a snapshot of where things are now with affected folks in the US.
Michelle Decker and Nicole Warren, thank you both so much for joining me. I can't wait to see what you all come up with in your new center.
Thank you, Stephanie.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Grace Ceciri. Audio production by J.B. Arbogast, Holly Cardinale, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Ceciri and Eliza Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.